Hi there, my name is Dre. I am the host and founder of the Dragon Network, which is a private virtual community where health IT professionals can share ideas, discuss their experiences, and collaborate with one another. So I also work as a healthcare IT consultant under Dragon Consulting. And as part of my consulting role, I'm frequently asked to give presentations on subjects that I'm familiar with to new and upcoming leaders or individuals in the field of informatics that want overviews on particular subject areas. So I was asked to give one of those presentations tomorrow on an introduction to US healthcare for non US citizens. In this case, it's for Canadians. And I thought while I was running through the slide deck and practicing my timing, I should record it and put it up here in case it's helpful for someone else. So I am going to go ahead and do that, and just let me share my screen. All right. So this particular intro to US healthcare is going to have a focus on information technology. So again, this is being presented to a group of upcoming informaticists that are looking more towards leadership. And in this particular instance, they're studying for their CPHIMS exam. So the agenda has been broken into three parts. For this particular YouTube video, we're only going to go into part 1 and 2. The general discussion will hold for later. And the first thing I want to talk about is the payment structure. So it might seem a little bit strange to talk about payment structure when I'm diving into IT, but it's very relevant to the legislation and important that you have the background context for that. So the second layer that I'll talk about is the healthcare legislation, and I'm going to focus specifically on the healthcare legislation that applies to IT. So in the US healthcare system, there are essentially four different aspects to the payment structure. So in 2019, according to CMS, 92% or close to 92% of the population did have health insurance coverage for all or part of 2019. They don't specify what period of time the part of 2019 needed to be. So the four categories are Medicare, Medicaid, the CHIP program, which is children's health insurance, and private or employer-based insurance. So I'm going to dive a little bit deeper into each one of those. I'm not going to do a super deep dive into any of these. If you want more information, healthit.gov or cms.gov have tons of information for you there. So we'll start with Medicare. So Medicare is a federal program. It is for individuals that are 65 and older, but it also includes some under the age of 65 with certain disabilities. And it also includes individuals with end-stage renal disease, so ESRD, who have permanent kidney failure and require dialysis or a transplant. So there are very, very clearly defined rules as to who's included and who's not, which disabilities are included and which ones aren't. But in general, these are the three categories of people that are covered by Medicare. So in the 2019 calendar year, about 61.2 million participants were enrolled in the Medicare program. And of those, just over 52.5 million were aged, so 65 and older. And then we have just under 9 million that were in the disabled and ESRD category. So Medicare itself is broken down into multiple parts. So I'm going to talk about A, B, and D here, and then we'll get to C on the next slide. So Medicare Part A is hospital insurance, and it covers your hospital stays, your care in a skilled nursing facility, hospice care, and some of your home health care. The Part A component of Medicare, if you're a Medicare enrolled participant, usually doesn't have a premium attached with it. There are some instances where a premium could be attached, and I'm not going to dive into details on those. But if there is a premium attached to it, then there's varying different costs that are associated depending on your background, your income status, and things like that. And those range all the way up to $458 a month. But again, for the most part, in general, most participants, Part A is no cost. Part B is your medical insurance that covers your doctor services, your outpatient care, some of your medical supplies, and more preventative services. In general, this one is a premium component. The standard premium that has been assigned to 2020 is $144.60, and that's a monthly cost. The third section I want to talk about on this slide is Medicare Part D, and that is your prescription drug coverage. So prescription drug coverage is not included in A or B, but you can have Part D that is either purchased or bundled or added in, and we'll talk a little bit more about that on the next slide as well. And this particular part includes your prescriptions as well as a lot of your vaccines or shots that you might need to get. So there's two sort of ways that Medicare is administered, and that is through Medicare Original or through Medicare Advantage. And it's the Medicare Advantage that's actually Part C. So Medicare Original includes Part A and B, so your hospital and your medical insurance. Services in this category are paid as they are received, so you get billed as services occur. There is a general deductible that resets itself at the start of each calendar year, and a copayment that is attached. The copayment can be different depending on where you are, and it's around 20%. It also can be different depending on what service it is. So Part D can be added on for additional drug coverage, and Part D typically has a cost associated with that as well. So the Medicare Original pays for most of the healthcare services and supplies that are covered underneath the Medicare program. You also have the ability to add a Medigap policy, and this can help you pay for some of the remaining costs. So if there are those exception things that weren't covered, it will help you pay for some of those. And it can also help out with things like your copays, your deductibles, and some of the extras. So the other alternative is Medicare Advantage, and you'll probably hear a lot of Medicare Advantage advertisements on TV. You might hear it discussed just in general conversations. You might read it in articles. So Medicare Advantage, or Part C, is really a bundle of Part A and B, and often D as well. So it also includes extra benefits like vision, hearing, dental, things that aren't captured on Medicare typically. And there are yearly contracts that providers, so insurance providers, would have with Medicare. So they must follow Medicare's coverage rules, but they can be administered by general insurance companies. So each Medicare Advantage plan can charge different out-of-pocket costs, and they also can have different rules on how you get services. So depending on who the Medicare Advantage plan is offered and administered by, there can be a lot of different rules associated with it. So I'm not going to dive into those, but just from a general awareness perspective, it's important to note that there's Medicare, and then there's Medicare Advantage, which is Part C. So Medicaid is a federal and state assistance program. It is for individuals of all ages who are in low income brackets. So patients often have no cost towards covered medical expenses, and in some instances may have a small copay. The program itself is run by state and local governments, but federal oversight really applies the rules. So that's where the federal and state sort of component comes in. And it's also important to note that individuals that are on Medicaid do have the ability to be on Medicaid and Medicare at the same time. So these individuals are considered dual eligible. So if you qualify for Medicare, so again, being ESRD with a certain disability or 65 and older, you can also qualify for Medicaid. So in the 2020 year so far, there are about 66.7 million participants that are enrolled in Medicaid. So again, Medicaid is state and federal, so state-run, federal oversight, and it provides health coverage for individuals, families, children, pregnant women, elderly, people with disabilities, really anyone who qualifies. The important part is to remember that you can be dual eligible if you qualify, and that it is an assistance program to remove some of those premiums and copays and things that you would have with regular insurance if you're unable to afford them. So CHIP is the third program. So this is the Children's Health Insurance Program. Again, this is a joint federal and state funded program. So federal oversight administered by states, very, very similar to Medicaid. The insurance program is for children and families who earn too much to qualify for Medicaid. So Medicaid, you'll remember just in the last couple slides that it covers all ages, so it would apply to children as well. CHIP is really a program that is meant to assist individuals who still need some assistance from a child's insurance program perspective, but don't qualify for Medicaid. And it's to encourage all children to be covered under their programs. So the May 2020 stats on that were 6.7 million participants in the US fall under the CHIP program. So similar to Medicaid, each state offers CHIP coverage. It does need to align with their Medicaid program, and that's because it's covering the people that Medicaid does not. Some states also choose to offer CHIP coverage to children and pregnant women, so it's not necessarily just for children. For the most part, the majority of them, it is just for children, but some do offer children and expectant mothers as well. So coverage and costs are different with each state, but the payments in general for CHIP participants cannot exceed 5% of the family income. And the other thing that is sort of fairly heavily regulated with CHIP is that CHIP programs must cover routine checkups and dental with no copay. They must also cover immunizations, doctor's visits, prescriptions, some vision, emergency services, inpatient care, outpatient care services, and lab and x-ray services. So it's fairly comprehensive from a general care perspective. There are, of course, rules and permutations throughout, but overall, it's a fairly robust program. So the next one that I would like to talk about is the private insurance section, and I'm going to break this one down a little bit more. So the first thing I want to talk about is Obamacare. I've got it in air quotes because it's not officially called Obamacare. It just happened to have been passed when Obama was president and has sort of taken on that name from an overall perspective. It is private insurance that you purchase through insurance exchanges that are regulated by the Affordable Care Act. So the Affordable Care Act, which we'll dive into a little bit more in a bit, created these health exchanges, insurance exchanges, where groups of insurance companies would present their offerings covering a standard set of components so that individuals that were looking for insurance had one easy place to go to compare plans, one versus the other. So it was very difficult in the free general market for people to understand how to compare one provider over another, because the way that the plans were described and what they were covering and how the copays and the deductibles and everything was layered, it was really difficult to sort of compare apples to apples. So one of the things that the Affordable Care Act put in place was these insurance exchanges to make that a little easier for everyone. So in order to participate in these exchanges, they must comply with government regulations, even though they're not run by the government. And again, most of those are focused around, what they offer, how they offer it, how it's sequenced, how it's presented, that type of stuff. So they are offered by traditional insurance companies such as Kaiser, Anthem, Cigna, Molina. So Obamacare, or part of the ACA, is available to anyone who is a legal resident of the United States. You cannot be enrolled in Medicare. And there is a subsidy program that's also available. So the subsidy program that's available applies to anyone whose income level is between 100% and 400% of the federal poverty level. And that federal poverty level changes every year. In states that have expanded Medicaid, the income range is between 139 and 400%, and that's because expanded Medicaid covers up to 138% of federal poverty level. So in general, think of it between 1 and 4. The individuals who are looking for subsidy can't be eligible for Medicaid. So you can't enroll in one of these exchange policies if you're involved in Medicare at all. But if you are eligible for Medicaid, Medicare, or an employer-sponsored plan that provides affordable and comprehensive coverage, there's also some rules around whether or not you can get subsidies. If your income level is above 400% of the federal poverty level, you can still purchase a plan on the exchange. You just have to pay the full premium, so you're not eligible for the subsidies. And in general, there isn't a lot of restrictions on that part. It's really just around the subsidy program and if you're enrolled in another federal program. So last but certainly not least is private insurance. So private insurance that is purchased in the private sector. So again, Obamacare is private, but this is purchased in the private sector, not on the Affordable Care Act exchanges, or it is employer-sponsored programs. So individuals that get health insurance coverage through their work. So now I want to dive a little bit into healthcare legislation, and you'll understand when we go into the healthcare legislation component why I felt that it was necessary to go over the way the payment structure works, because it'll really give you a sense of how this is layered on top of it and how IT fits into this whole thing. So in general, the Department of Health and Human Services is the overarching federal government branch that looks after most of this stuff. So some of the relevant sections that fall under the Department of Health and Human Services are the Center for Medicare and Medicaid Services, so that's CMS, the Centers for Disease Control and Prevention, which is CDC, the Food and Drug Administration, and the Office of the National Coordinator for Health Information Technology. So I have stars beside CMS and ONC because those are the ones that we're really going to dive into from an IT perspective. That's not to say that others like CDC or FDA or even some of the other branches aren't relevant to health IT. But in general, CMS and ONC are responsible for a lot of it and for ensuring that the requirements are met. So those are the two we're going to look at. Just over the last decade or so, there have been several key legislative milestones that relate to information technology in the US. And these sort of 6 elements that I've laid out on the screen here have really shaped the way that not only healthcare is delivered, but the way that IT has sort of progressed in the last decade and really set the stage for how it's going to continue to progress in the coming years. Starting in February 2009 with the American Reinvestment and Recovery Act, which is ARA, we lead ourselves through meaningful use, stage 1, 2, and 3, Macra, which is a Medicare access and chip reauthorization, and finally to March of 2020, which is when the final rule for the Cures Act and promoting interoperability came out. I'm going to walk through each of these in a little bit more detail to give you an idea of how they relate to IT. So the American Reinvestment and Recovery Act, which is ARA, was part of the overall legislation that was brought forward after the 2008 market crash. It was in place for a number of things. It actually contained the bailout for banking and auto industries and things like that as well. But as part of ARA, which included all those many things, there was a section that was aimed at modernizing healthcare infrastructure. So that was the Health Information Technology for Economic and Clinical Health Act. So that is known as HITECH. If you're in IT, you'll hear that a lot. And this is sort of one of the things that came out of ARA. So HITECH was created really to help expand and promote the use of electronic health records. So there was a notable slowness in adopting technology in the healthcare space compared to the rest of the industries. And, building on top of the whole dot-com bubble and the market crash and things like that that had occurred, the government chose to put some frameworks and parameters in place to try to encourage and promote the use while having control over it from a healthcare perspective at the same time. So the most important thing that we'll look into is meaningful use by who. So who is this? Who are we talking about when we're talking about all of these legislative activities that have gone on? So there's 3 main categories when we're looking at healthcare legislation, and they are EH, CAH, and EP. So EH is eligible hospitals. So this is any hospital that's paid under the inpatient prospective payment system, which is, of course, another program that crosses over into the Medicare and Medicaid world. And that refers to acute hospitals, including cancer hospitals and critical access, who have at least 10% Medicaid patient by volume, as well as children's hospitals. And for the children's hospitals, there's no Medicaid patient volume requirements. So all the children's hospitals and acute with 10% Medicaid and higher. Critical access hospitals are included in that, so they're rolled up into that, but I wanted to break down what a critical access hospital is a little bit more because it is relevant to CPHIMS, and I thought it was important to understand the difference. So a critical access hospital has no more than 25 acute care beds, and the average length of stay for acute care patients has to be less than 96 hours, and that's the average. At acute care hospital for critical access has to provide 24/7 emergency services. So they have to have an emergency room and it has to be open all night. And it must be greater than 35 miles from another hospital. If it's in an area where only secondary roads can be used or there's very mountainous terrain, then that is reduced to 15 miles. So it can't be right next to another hospital. The eligible professional side is really a wide array of healthcare providers and clinicians. So it's a minimum of 30% Medicaid patient volume. And again, Medicaid is the state different ones. So 20% of the volume if it's a pediatrician. So it's lower if it's a pediatrician than if it's a non-pediatrician. And they need to practice predominantly in a federally qualified health center or a rural health center. So federally qualified health centers are often referred to as FQHCs. So again, these eligible professionals includes doctors of all sorts. So doctors of medicine, osteopathy, dental surgery, dental medicine, podiatry, optometry, etc. Chiropractors, nurse practitioners, certified nurse midwives, dentists, physician's assistants, again, where the physician's assistants are in FQHCs or rural health centers. So you can see between the eligible hospitals, the critical access hospitals, and eligible providers, the rules that were put forward with ARA and the HITECH Act that led us into the meaningful use legislation, they really are applying to a very large number of clinicians in the US. So if we look again at the Medicare and Medicaid population and sort of spread that out across all practitioners and then layer on who these eligible providers are and who these eligible hospitals are, we're really touching almost everyone. So there's very, very few who do not fall under this or do not in some way relate to these pieces of legislation. So this is where we get the layering effect where IT is really controlled at a federal level, or not controlled, guided at a federal level, but put in place across the board. So I thought that was important to note. So July of 2010 is when meaningful use stage 1 sort of really, got its legs. And the final rule that was released at that time was based on 5 pillars of health outcome policy. And those were improving the quality, safety, and efficiency of care while reducing health disparity, engaging patients and families in their health, and we're still working on that one, improving care coordination, improving population and public health. And the 5th one is to ensure adequate privacy and security protection for personal health information. So stage 1 was really the foundation layer that was put in place. It was from the very beginning always intended to be a multi-layer process, and they did intend to have 3 stages. So stage 1 was that foundation level and really focused on capturing clinical data electronically and providing patients with electronic copies of their records. And the electronic copies of their records that were required in meaningful use stage 1, that was just to put things on a thumb drive or to give them access through a portal. So it wasn't really what we're thinking of right now. It was just the beginning of that. So April 2015, we had meaningful use stage 2 come forward, and that was when the sort of final rules for stage 2 came out. Proposed rules had come out earlier. It really expanded on the stage 1 criteria and tried to put the focus more on advancing the clinical processes. So again, stage 1 was really to lay the foundation for technology. Stage 2 was really to start to incorporate some of the quote unquote meaningful use components. And it also increased the requirement to support the priorities of the quality strategies that had been put in place. So there were some quality measures that they were trying to work towards, and meaningful use stage 2 is really trying to align with those. So it also encouraged the use of certified EHR technology or CERT technology. So meaningful use stage 2 was looking to leverage CERT 2014 edition. And that was so we could have structured exchange of information and increase quality improvement at the point of care. So with stage 2 and its build upon stage 1, a lot of the thresholds that were in place for some of the measures increased. And then we also saw additional components for data capture and some additional interoperability requirements were added. Sticking in the 2015 realm, we also had something called Macra that came forward in 2015. So that was the Medicare Access and Chip Reauthorization Act. So again, you'll remember that CHIP is that Children's Health Insurance Program. So this particular piece of legislation how it became relevant is it repealed the sustainable growth rate payment formula that had been put in place in the US in 1997. So, what the SGR did is it tied certain Part B Medicare payments to US economic performance. So, how the economy was doing as a country would sort of tie into the payment formulas for Medicare Part B. And again, that Part B is your medical office visits, your um, outpatient care, and things like that. So, as you can imagine, with the Medicare Part B payments tied to economic performance, there was a high potential for significant fluctuation in percentages. So, that had the ability to drastically change from year to year, which was not seen as something that was very good for the long term. So, it was repealed with Macra. So, when it was replaced with a quality payment program, and there was two tracks that you could choose from. And so again, when we're talking about individuals choosing for these tracks, we're really talking about the eligible professionals because this is focused on Medicare Part B. There was the Advanced Alternative Payment Models, which was APMs, and that required that all the participants use certified EHR technology. So that cert technology that we saw introduced with meaningful use comes back again with this. And then we also have the second track, which is merit-based incentive payment, which is MIPS. So MIPS is actually part of Macra. You'll often hear MIPS and Macra talked about together fairly frequently, and there can be some confusion as to how they interact with each other. MIPS is one of the tracks under Macra. So what MIPS does is it is the promoting interoperability category to really focus on meaningful use of your technology. So again, it also requires certified technology. It's more in line with the meaningful use sections that had been put out before. And it really is laying the groundwork for what often is referred to in the industry as value-based care. So if you prove and utilize, so if you prove your pathways and utilize your EHR technology to demonstrate outcomes, then there are incentive payments that are in line with those. So that's how MIPS sort of fits into everything. October of 2015, we're still hanging out in that same year. We have the introduction of Meaningful Use 3, this final piece of legislation. This also included a modification to some of the stage 2 rules. What this did was it focused on, again, using CERT. So it switches over from 2014 CERT to 2015 CERT. And the 2015 CERT was optional but encouraged. So 2014 became mandatory, 2015 was optional and encouraged. And it aligned the reporting years with the calendar year. So we see with a lot of the other programs, so the inpatient quality program, for example, that I mentioned earlier, that follows a calendar reporting year. And meaningful use was following an October through September fiscal year. So this stage 3 component really switched that so that all of the reporting requirements that hospitals and providers and critical access hospitals had were going to be in line with the calendar year. So they could stick their reporting to the same time components because there's so much overlap between it when it comes to technology and reporting. So I do have a note down here that in April of 2018, CMS actually renamed the EHR incentive programs, which we think of as meaningful use, to promoting interoperability program. So the program didn't vanish. A lot of people wonder, whatever happened to meaningful use? Well, in 2018, meaningful use was rebranded to promoting interoperability. I thought it would be helpful just to let you see what the 2020 requirements are for meaningful use. So I looked at the reporting requirements for eligible hospitals and critical access hospitals. And a couple of the key components are they are required to use a 2015 edition cert, so the Certified EHR Technology 2015 edition. They need to report on measures for 4 objectives, and there's a scoring matrix that's associated with each of the objectives. And in that scoring matrix, they need to score greater than 50%. So passing grade has to be over 50. They also have to report on 4 clinical quality measures out of 8 options. That used to be 16 options for 2019, and it was switched to 8 options for 2020. So critical access hospitals and eligible hospitals have to attest yes to the security risk analysis. They have to attest yes to the prevention of information blocking, and we'll talk a little bit more about information blocking in a second. And they have to attest yes to an ONC direct review, so they have to be willing to be reviewed by ONC. So this slide, I'm not going to go through the whole slide. I'm just going to sort of leave it up here for a second and highlight that this is sort of how the point structure is broken down. And again, they need to have 50 points or higher in order to sort of make it through, if you will. The 4 categories that we talked about are electronic prescribing, health information exchange, provider to patient exchange, and public health and clinical data exchange. So we really have, with stage 3, reached the point where regulations and the legislation is trying to make the use of the technology and the use of the reporting structure relevant. So it's no longer laying the groundwork like it was in stage 1. Stage 2 is really getting used to everything and sort of adding in more things. Stage 3 is really where they did focus on, okay, let's report, let's exchange data, and let's make this meaningful. So here are your 2020 requirements for eligible hospitals and critical access hospitals. So that brings us to March of 2020. So in March of this year, Center for Medicare and Medicaid Services and ONC, the Office of the National Coordinator, they both released legislation at the same time. So the 2 rules came out together for a couple of reasons. The most important being they wanted to demonstrate alignment with each other. So the ONC rules for the Health IT certification program and the Promoting Interoperability final rule really wanted to demonstrate that they were aligned. There's a lot of components between the 2 that relate. So a lot of the PI rule relates to the 21st Century Cures Act. So you'll see a lot more alignment than you had in the past with other pieces of legislation. So the 21st Century Cures Act, which was released by ONC, is 1,244 pages. So I have read some of the Cures Act. I have not read the entire Cures Act. I haven't made it quite through it yet, but it really is the one that's focusing on interoperability, information blocking, and further clarification of the certification program. It includes a variety of different things and really applies to a whole bunch of branches within HHS. So there's support for medical research, there's clarifications on HIPAA, there's some substance abuse and mental health services components to it. But the part that I really want to sort of highlight today is that ONC has responsibility for implementing some sections in Title IV. And those sections, there's 5 of them in particular. So that's section 4001, which is health IT usability, 4002A, which is the conditions of certification, again, for those certified health IT systems. 4003B, which is the trusted exchange framework and common agreement. So I do have a webinar that is posted on my other channel, which I can link to in this description, that goes over what TEFCA is. Then we've got 4003C, which is the Health Information Technology Advisory Committee, and 4004, which is the identifying reasonable and necessary activities to focus on information blocking. So those are the 5 sections of the 1,244 pages that really are key for health IT individuals to focus on. As I mentioned, at the same time, the Center for Medicare and Medicaid Services released their final rule, which is promoting interoperability. So this is a program that was focused on the exchange of data between and across health systems and across organizations, as well as patient access to their health information. So in the Promoting Interoperability final rule, there are several new policies, and the highlight of the policies I've got listed: Patient Access API, which is going to kick in January 1st of 2021, the Provider Directory API, which January 21 as well, Payer-to-Payer Data Exchange, so that one doesn't kick in until 2022, improving the duly eligible experience by increasing the frequency of the federal state data exchanges, so that one's 2022. And you'll see we're continuing to layer in the Medicare and Medicaid components throughout this. So this again is really highlighting the fact that it's hard to get away from the payment part with the healthcare legislation for IT. So public reporting and information blocking, and that information blocking component is very heavily tied to things in Title IV of the Cures Act, which is the information blocking components of that act. And the digital contact information policy is in here, and as well there's a ADT, admission discharge transfer event notification policy. So I will note that with COVID, so these dates were the original dates for the policies that are contained within the final rule. Some of these dates have changed, and some of them have been relaxed. Some of them are just not going to be enforced for later times. And we're still waiting to see if there are further changes that are going to happen with the timeframes, just with the fluidity of COVID and how everything's happening. But again, these dates are the dates that were included in the final rule, so some of them may have changed. So promoting interoperability, the other thing that it does is it really focuses on implementing some IT standards. So there are some pretty big sort of changes that have occurred. And how that is important is in the US healthcare system now, when this promoting interoperability rule is first required to be reported on, by putting these standards in place and by having all of the focus around these APIs, what we're going to do is we're going to see in general healthcare, we're going to see almost every player who is really in the global market, but definitely every player in the US market, they're going to have to align with these standards. So the chances of them utilizing different standards outside of the US and recreating their applications, it's too big of a market for this not to be relevant. So the key ones that were put in place or will be put in place when these become effective are HL7 Fire. So Fire, in particular, version 4.0.1 becomes a requirement. The Smart Application Launch Framework, Release 1, so the Implementation Guide Release 1, and that is in line with OAuth, so OAuth version 2. The OpenID Connect, so that's for end user identity verification on an API, so OpenID Connect version 1.0. And the other thing that is being put in place with promoting interoperability from a standards perspective is the US CDI. So that's the United States Core Data for Interoperability, version 1 of that. So that is a standard set of health data classes and component data elements that really cover all sorts of things. So they have elements from, immunizations, patient demographics, clinical data components, really just there's a lot of them that are in there, and it's a very important data set that I think from an IT perspective we need to pay attention to globally. I don't think it can just be isolated to the US. I think we really need to see, and a lot of the individuals that are working on those standards are working on them in collaboration with other countries and work in collaboration with international components. So it's definitely not something that's isolated to the US. Certainly something that's relevant for everyone. So I've put the website here for you to take a look at and see how things are going. That is a version 1 is there now. So it is a work in progress. So that brings me to the conclusion of my presentation today. So as I mentioned, I was preparing this for a group of individuals that we're going to have time for open discussion. So we'll jump into that there. But for this YouTube video, that's where I'm going to end it. If you want to find more information on these things and have conversations and really just learn more about what Dragon Consulting and the Dragon Network are all about, I encourage you to go take a look at our website and sign up for a trial membership if you'd like. And I hope to see you inside there, and I will see you the next time a video comes out. Don't forget to subscribe so you'll be notified. All right, see you later.